hope you're doing well. Today we're going to look at sex chromosomal abnormalities. By the end of our discussion, we should have looked at the introduction, the definition, the types and the classifications, Turner syndrome, Klinefelter syndrome, and management of these conditions. Sex chromosome abnormalities are a group of disorders which affect the number or the structure of X and Y chromosomes. In other words, the abnormalities that affect the sex chromosomes. They occur by either missing or having an extra copy of the X and Y chromosomes. The most common examples are the Turner syndrome and Klinefelter syndrome. So in the classification, you can divide them under either structural or numerical. So in structural, you have a change in the structure of the X or Y chromosomes. Then in the numerical is the change in the number of chromosomes. Under numerical, you can have either monosomy. Mono means one, and then it means that there is only one chromosome instead of having a pair of the sex chromosomes. Then trisomy, tri means three, somy chromosome, therefore you're having three chromosomes instead of having the normal pair of chromosomes. So under monosomy we have Turner syndrome as our major example, and under trisomy we have Klinefelter as our major example. Then of course there is Jacobs and then triple X syndrome. When you look at Turner syndrome, this is a condition characterized by complete or partial monosomy of the X chromosome, and it's defined by a combination of phenotypic characteristics. Therefore, in Turner syndrome, there's only one chromosome instead of having two pair of sex chromosome. But then there is complete, whereby the complete chromosome is missing, or there is partial, whereby a section of the chromosome is missing, either the short arm or the long arm. So half of the patients with Turner syndrome have 45X chromosome complement. The other half exhibit monozycism and varied structural abnormalities of the X and Y chromosome. So this mosaicism here is whereby within the same individual you have some cells having the X and Y chromosomes, then some cells are not having the normal number of chromosomes. In this case, they are missing the X chromosome. Maternal age is not a predisposing factor for children with Turner syndrome. This is as you compare to Down syndrome, which has been discussed in another video. You can check it out. The maternal age is a predisposing factor. Therefore, incidences of Down syndrome in the other case increase with increasing maternal age, which is a different case with Turner syndrome. The etiology, mostly three factors are listed here. There is the classic form, the 45 chromosomes, therefore one chromosome is missing, that is monosomy X chromosome. Then there is a case whereby we can call it a partial monosomy, whereby there is just deletion of a short arm of one X chromosome, but the chromosome is there. Then Turner mosaicism, we have explained this case where we said that within the same individual, some cells don't have the other X chromosome, but some cells have the X chromosome. Therefore, this individual is going to have different phenotypic or physical appearance. It's estimated that around 95 to 99% of these babies with Turner syndrome, sometimes they don't reach the age of viability, and therefore miscarriages occur. Clinically, these patients will present with short stature, congenital lymphedema, horseshoe kidney, patellar dislocation, shield-like chest, scoliosis. This is the medical abnormality with the concavature of the spine. It can either take the S form or the C shape. Then you have congenital hip dislocation, and then also on physical exam they will also present with widely spaced breasts. As highlighted in this picture, with some of the features here, we see in this picture there is a webbed neck, this part here, and a low hairline, and then also we have a low set posterior hairline here, and then you also have, this is lymphedema, whereby this is non-pitting edema of the feet and the hands. And then also in physical exam you may find these children having a C-cut shaped on the chest, which might indicate history of the previous surgeries as to correct the heart defects, because these children tend to have heart defects. The clinical findings in newborns can also include, of course, the ones we have seen before. Then you add small size for gestational age. Then you can have protruding ears and non-pitting edema of the hands and the feet. We have seen this. Then congenital heart defects are so common, that is 40%, and structural renal anomalies in 60%. So the most common heart defects include the defects in the bicuspid aortic valves, and then coarctation of the aorta. This may cause an increase in blood pressure. Then you have aortic stenosis and mitral valve prolapse, and these are going to affect the ability of the heart to distribute blood to the rest of the body. Therefore, these patients may also present with cyanosis. Then in adolescents, you're going to have streak gonads due to gonadodysgenesis. Then you also have primary amenorrhea and lack of secondary sex characteristics in an adolescent who has reached the reproductive age. Then most patients tend to be of normal intelligence, but intellectual disability is seen in up to 66%. So 6% of these children may also have intellectual disability of some kind. They also have increased risks of behavior problems and deficiency in impartial and motor perception. How do you diagnose an individual with Turner syndrome? Our diagnosis can base on one, history taking. You get the detailed history, the factors that were surrounding prenatal and natal period, and then also going to do physical exam as you're looking for the features that we have listed of Turner syndrome. You could do webbed neck. Then we should also do genetic testing, that is karyotyping. This technique makes it easier to visualize the chromosomal defects, hence identifying the condition. And then also there are some supportive tests that we can do. This can predict the likely complications that can develop with this infection, and therefore make us be prepared. All this can include frequent weight measurement, thyroid function tests, liver function tests, renal function tests. You can also do an echo and MRI to detect the different abnormalities in the heart valves. Then you can also do ultrasound scan In this case, you can even do over the abdomen to look at the kidneys. And then how would you treat this patient? You are not going to correct the genetic defect in these individuals, but rather you're going to manage the comorbidities. For example, you can do a surgery to protect and correct the defect in the heart. Therefore, you can do possible surgical repair of the cardiac abnormalities. You can do growth hormones to stimulate growth. And then you can also give estrogen replacement therapy such that you can initiate puberty in these individuals and surgical removal of the estrous organs. That's what I had for you today. I hope you enjoyed the lecture. I hope you have understood. I hope you have learned something. Check out my next video